All right, thanks everyone. So we're going to talk a little bit for the next few minutes about 3D echocardiography and 3D printing and its roles in adult structural heart disease. So here are my financial disclosures. And so here's the outline of what we'll talk about. We'll start with 3D echocardiography, and we'll use a couple of different diseases as case studies here: mitral valve disease, aortic disease, and we'll touch a little bit on left atrial appendage closure for those of you who might have some interest in that. And then we'll shift gears and go to 3D printing. We'll talk about why 3D printing in cardiac disease, the basic mechanistic parts of 3D printing, and then where we are in terms of the literature and use of 3D printing in structural heart disease. All right, so we're actually going to start with mitral valve disease, and we're going to start with mitral regurgitation. And the question is, why might 3D TEE be helpful in interventions in mitral regurgitation? And at least if you're talking about percutaneous interventions, well, this is what your interventionalist is looking at. They're looking at a catheter and then some lung and some rib space. And from this, they need to be able to visualize and actually work with the mitral valve anatomy. So 3D TEE, we actually know from the data, and I'll show you some of this, allows for a more rapid assessment of the mitral valve anatomy than 2D. It allows for more accurate planimetry of the mitral valve. And 3D color Doppler, we think, may be better than 2D Doppler to quantify mitral regurgitation. Okay, so a little bit to the literature. This is a study that's a couple years old now, and is actually from the surgical literature. So there was a single center. They took 237 consecutive patients, and they actually instituted a protocol that started with 2D imaging, and then as 3D imaging became more available, went to 3D imaging. All of their patients got this protocol pre-mitral valve surgery, and they actually looked at their findings over time and how well they did. So there was a concordance between the accuracy of your pre-procedural imaging and your outcomes, okay? And then that concordance was actually greater for 3D imaging than it was for 2D imaging. And perhaps most importantly for everyone in the room, the repair rates, the successful repair rates on the mitral valve increased from 46.5% to almost 78% over the time frame that they had this protocol. And they compared that to the national average in the STS database, which didn't really change much at all, 46.6% to 55%. So here's some real outcome data that instituting a protocol and going to 3D echo may actually help to improve your mitral valve repair rates. All right, wouldn't be an echo talk without some pictures. So here you're obviously looking at the mitral valve, okay, anterior leaflet and posterior leaflet. And we're trying to identify what's the mechanism of disease, because all mitral valve surgeons and interventionalists know that this is key. And you might get a sense that, okay, maybe there's some anterior and maybe even a little bit of posterior prolapse there. But what if I showed you this instead? So in the middle, we've got the aortic valve, tricuspid valve out here, pulmonic here, and here's your mitral valve. And I'm actually going to show you an even better picture, higher resolution, higher frame rate. And what you can actually see is there's a little flail segment here to the anterior leaflet, and you see this thing spinning around right here. That's the cord flipping back into the atrium, and this is the same thing from a ventricular view. So I think you could argue without data here at least that it might be easier and faster to assess exactly what's going on with the mitral valve with 3D imaging. Okay, so enough about mechanism. How about disease severity? I think everyone can see here we're looking at a 2D TEE image, and we see there's pretty significant mitral regurgitation. Looks like it's somewhere around A2, P2. Here's the anterior posterior leaflet view, and again says the same thing. But you can actually quantify this. There are 2D techniques to do this, and there are also 3D techniques to do this. And what I want to emphasize here is, at least in the setting of percutaneous interventions, nobody has validated the assumptions behind the 2D techniques. Without boring you all, essentially in a 2D technique, you assume that the opening of regurgitation is a circle. And I'm here to tell you, as you can see from this, it's never a circle. Never, never. It's some irregular shape. You don't have to make those assumptions when you use 3D color TEE. Okay, so what's the data for that? What you're looking at here are bland Altman plots. So the point of these plots is this. You want all your dots to be as close to this central line as possible. So what this first plot is showing you is, here's the difference between 2D TEE and 3D TEE. okay, as compared to the average of the values. So there's some difference. Not all the dots are on the line. And now let's compare 2D TEE to MRI. Okay, they're close to the line, but let's look at 3D TEE to quantitative MRI and look how much closer the dots are to the line. So at least if you believe that quantitative MRI is the gold standard for mitral regurgitation, 3D TEE seems to do a better job of it than 2D TEE. And now a little bit of a glimpse into the future. So I've shown you data for essentially techniques that are widely available and widely used now. And what this is automated real-time quantification of valvular regurgitation. And so right now this is not widely available, although it's done at some centers. And again, I just want to point you to these plots. So these are sort of correlation plots where you want everything to be on this central line. And what you're looking at here is 2D TEE versus cardiac MRI, and you see there's some splay along the line. Here, and that's for mitral inflow, stroke volume, and this is for aortic stroke volume, and again, there's some splay of the dots along the line. Now here are these automated real-time color 3D techniques, and look how much closer the stroke volume estimates are either from the mitral inflow or from the aortic outflow, much closer than 2D techniques if you use cardiac MRI as the gold standard. So this is coming down the road. And in fact, we're going to have a protocol here at Duke starting to use this within the next couple of months. Okay. Unless we forget, 3D TEE is actually really valuable in paravalvular leak. I'm just going to show you a quick example here. We're not going to go through a whole case in terms of plugging the leak. But what you're looking at here is obviously a mitral valve. There's a ring in place, and there's some leaflets underneath. And you seem to see a little bit of a gap here. The question is that gap just dropout? Is there actually going to be severe mitral regurgitation there? Okay, and here's the same thing from the ventricular side. And now we actually turn on the 3D color, and you can actually see that most of the color here is coming through the leaflets and not in that area that looks like a gap. So this kind of technique is really helpful to visualize exactly where the MR is coming from. In this case, it's mostly through the valve, but you could imagine a case where it's paravalvular as well. And then using that technique to guide your interventionalist to plug these leaks can be very, very valuable. Okay, so something that's now sort of just hitting practice is intraprocedural fusion imaging. What do I mean by that? Well, this is what I mean by that. What we have here, here's a fluoro image. You've got the TEE probe in the image. And what's overlaid here is actually a TEE image. This is the bicable view overlaid onto the fluoro image. And here's the actual TEE image itself. And we've placed markers here at the inferior and superior aspects of the image. And those markers show up on the fluoro. So normally when you're doing a transeptal, and you're the interventionalist, you really don't have a whole lot to look at here on your fluoro image. But by overlaying your bicable TEE image and actually putting markers on the inferior and superior aspects, it gives you a little bit of a target to aim for as you're doing your transeptal. Okay. And then here, just an example of as we're doing the transeptal, you can see the catheter coming through. This is a 3D live TEE image, and this is what's called a free image. I'll show you another example that's perhaps more useful in a second. And this can be rotated in any dimension you'd like. So you can look at it in two different views at the same time, while of course having your fluoro image, and you can see the guide sheath here as well. Okay, so where else might fusion imaging be useful? Well, this is real-time 3D TEE imaging in a MitraClip case. Here's the catheter, and we're trying to position it over the area of the leaflet that's prolapsing so that we can make sure we clip that area. And this is pretty widely available and standard in how this is done now. But how about a fusion image here? So on the top, here's the live 3D TEE, okay? And then here we have our free view. So we've actually cut into it and turned it on its side. So you have orthogonal 3D views at the same time that you have the echo overlay on the fluoro, so that you can see exactly what you're doing in every dimension that you need to, so you can orient the catheter appropriately to grab the correct leaflets. And I would say ideally when this works well and is applied well, it should shorten the amount of time it takes to position your catheter. And just another example here, once the clip is in place, you have a dual orifice mitral valve, and you can actually see something similar here in terms of an overlay of a 3D image onto the fluoro. Here you can see the mitral valve opening. Here's the clip in place. I'll skip through this. Okay. So how about for MS? Where might 3D TEE be useful there? So our typical techniques, of course, are to look at gradients and measure gradients across the valve in terms of MS. But we know that the mitral annulus is saddle-shaped, and doing planimetry of the mitral annulus is very, very difficult by 2D techniques. Well, that's where 3D comes in, and there's actually pretty good data to suggest that you can do fairly accurate planimetry through the leaflet tips using a 3D image of the mitral valve. Let's move forward now to TAVR and the applications of 3D TEE there. So just a little bit of summary as we go through. So 3D TEE in TAVR has been shown to be superior to 2D in terms of improving sizing of the TAVR valve, in terms of aortic annulus measurements, and there's some data out there to suggest that it's similar in accuracy to CT. And it may actually be superior to 2D imaging for the quantification of PVL as well. So why might this be? Well, if you look at the aortic annulus here, like everything else in the heart, it's a three-dimensional structure. And the guidelines would suggest that when you look at PVL, what you're trying to do is understand the vena contracta, or the narrowest jet of the paravalvular leak through the valve. And so they suggest that you do this in a short axis view. And the question is, when you're scanning the patient and you do your short axis view, is your view up here? Is it in the middle, somewhere in these two? Is it down here in the ventricle? It can be very, very difficult to tell. And this is important because the amount of regurgitation you'll see, look for the blue areas here. This is up high, just a little bit of blue. As we get lower, more blue area. And when you get into the LVOT, it gets bigger and bigger. And we know that the grading of PVL is supposed to be done by how much of this clock face is taken up by the blue in this image. So you really do need to know exactly where you are. Now, doing this with 3D acquisition, you can actually just take one image and you can go back and scan through the image, go up and down in it, and see exactly where you are when you get your clock face view. So you can have this clock face view up here at the sinuses, down here closer to the leaflet tips, and in the LVOT, and you can make the measurement in each one of those cases. And what I've shown here is an example where we've actually traced out the area of the regurgitant orifice, and it's 4 millimeters squared. And again, just to touch on where 3D TEE may be useful in terms of Watchman cases, for those of you who aren't familiar, typically what needs to happen, this device is a square. It's about the same diameter as it is in depth or length. And so your left atrial appendage needs to fit this device. It needs to be, the os needs to be about as wide as the entire thing is deep. And so what do? We go through, we take images at a set number of angles. There's no data behind these angles. These were made up by the person running the core lab for this trial, and that person happens to be at Duke. And she made these numbers up, and that's what was used in the trial. And then we take measurements, and we use those to decide how big the device should be. But what if I just took one 3D image of the left atrial appendage? And what you're looking at here is actually that 3D image, and it's being rotated here. Here's the os of the left atrial appendage, here's the ligament of Marshall, and here's the left upper pulmonary vein. And what you can do from that one 3D image is you can actually take measurements in every single angle. So it doesn't just have to be 0, 45, 90, 135. And you can find out exactly what the greatest and minimum diameter is. And again, the reason for doing this is the os is never a circle. It's something else. It's an oval. And you can actually take it at multiple levels as well to decide exactly how deep you want to put the device depending on the size of the device. Again, fusion imaging in this case can actually be really helpful. Here's the left atrial appendage on fluoro. Surprise, you don't see anything. Here's the catheter. These rings actually tell you where the top of the device is going to sit depending on the device size that you pick. what's really helpful to know is to overlay the echo image on top of the fluoro so that you know your device is going to sit within the left atrial appendage and not outside in the left atrium where it may breed clots. And just for the curious, this is what it looks like when it's done. In this particular case, here's the device on the catheter. There's a bit of a gap here, and you can see that here on 2D, and so we repositioned this before we left this in the patient. Okay, we're going to switch gears here in the remaining minutes and talk about 3D printing in structural heart disease. So here's my history with 3D printing. If you can't think in 3D, you cannot be a cardiologist. So said Michael Crawford to a certain resident in San Francisco around 2006. And then for those of you who follow the MitraClip literature at all, Elise Foster, I don't think 3D echo adds much for me over 2D echo, again said to a certain resident. And for the rest of us, okay, the truth is we're not as skilled as Dr. Crawford and Dr. Foster. What you're looking at here is actually a clinical trial, or a trial done in a group of medical students who are trying to learn neuroanatomy. And they took 101 students and they broke them into half, and they taught traditionally for half of them, and they used 3D models to actually teach neuroanatomy for the other half. And these are not meant to be read, but suffice it to say, the people who got 3D model-based teaching of neuroanatomy did better on their anatomy exams than the people who had regular standard curriculum. Okay, so what about visual spatial reasoning? I think everyone would say that's pretty important within cardiology. This example, this is a paper again, but this is an example from the orthopedic literature where they actually asked people to rotate these vertebrae, spinal vertebrae, in their mind and figure out how these vertebrae would fit together. And again, what this study showed basically is that there's a wide variety of people's ability to do this, and that can be tested and shown. Okay, so not everyone's created equal, and 3D models may actually help people to learn anatomy. So with that background, and that's really the extent of the background in our understanding of how 3D prints might help in teaching and in pre-procedural planning, here's what we think may be the evolution of 3D printing and its uses in structural heart disease. So step one, this is the simplest thing, accurate reproduction of the anatomy. So we're going to look at the anatomy and we're going to understand it, and in some way that's going to help us to do the case. Step two, how about we actually reproduce physiology and anatomy with a 3D print? That might be helpful. You can imagine having a 3D print, being able to deploy your TAVR into that print and then assess it for PVL, all before doing this in the patient. And then I would say there are a couple other steps in terms of where it might fit in with actual use in the real world. And this is, I think, step three, an important one. So in this time frame, we have to be talking about demonstration of cost effectiveness and what kind of marginal value 3D prints add on top of what we're already doing in clinical variables. And then perhaps the holy grail is specific device manufacturing. So this is actually already done in orthopedics, a little bit in vascular surgery, definitely done in ENT. We're not quite there yet in cardiology, but could you imagine printing your own 3D printed TAVR valve specific for your patient? All right, so let's skip this. There's actually many different types of 3D printers out there, and this is just to give you a sense of how many different types there are, okay? And we're going to go over a little bit of the most commonly used ones and what their pros and cons are. So this is the most commonly used. It's called FDM, or extrusion. So when you go on Amazon and you find the $200 3D printer, that's what this is. So it basically melts plastic onto a heated layer, and each layer hardens as it's deposited and bonds to the previous layer. And so because you're doing this, there have to be supports printed on this as well. So you're not just going to print your valve. There's going to be a bunch of support network that comes out with it as well. The pros are it's pretty accurate, reliable, and cheap. But when I say pretty accurate, I don't mean millimeters accurate. I mean like centimeters accurate. so maybe not so great for your own 3D TAVR valve. And it certainly does require removing those structures afterwards, which can be a painstaking process, the things that are holding it together. Okay, so stereolithography. This is a little bit less commonly used, but a lot more dimensionally accurate. It's actually the original type of 3D printing, and it's a photopolymer resin that reacts with a laser to actually form a solid. It does also require support structures, but look at the accuracy, 20 nanometers of accuracy. So this is the type of technology we're talking about for medical grade 3D prints. Something that's coming to the forefront, DLP, or digital light processing. This is, again, similar to stereolithography, uses a lamp instead of a laser to actually put down the material. And it also requires support structures. It's also very accurate, but somewhat cheaper than stereolithography. And then, just to give you some sense of how involved this is becoming and where this is going, this is electron beam melting. So this is actually using photo array of electrons to actually cause deposition of material. As you can see, currently only one Swedish company is making this, but you can use this to make metal parts. So that's why I bring it to your attention here. Okay, so the question is, what kind of material can you use in 3D printing? It really depends on what you're trying to print and what type of printer you have. There's many different combinations, but materials go all the way from paper through titanium and ceramic you see here as well. So where are we in terms of the literature for 3D printing right now? So I'm going to take you through a couple of publications, and just keep in mind that the maximum N for all of these publications put together, I think, is about 15. So the first step is just looking at anatomy itself, and what this paper did was they took a CT scan of patients who are going to undergo TAVR. They literally printed the aortic root, and then they measured the thickness of the aortic root via CT versus the wall thickness of their prints, and they correlated it and said, yes, it looks about the same. So we can print what we get out of a CT. This goes a little bit further. This is an actual demonstration of physiology, and this was done in a few patients at Methodist down in Houston. And so again, this is a CT, and you can actually see here's an aortic root and ascending aorta. Here's calcium on the leaflets. They printed it like the other group did, but then they actually TTE'd the patient and then TTE'd the model, and they actually showed that their gradients through the aortic valve were somewhat similar, and they hooked this up. You might say, what was the gradient? What was the fluid? They actually hooked this up to an LVAD to do this, one of the older LVADs that's not continuous flow. Okay, so how about actually using this in sort of clinical assessment? So this was a study done by a group that included docs up at the Brigham, and they printed their aortic roots, and then they actually 3D printed replicas of TAVR valves. And what they've done then is they did measurements of the TAVR valves as compared to the CTs, and they said, yes, our aortic roots and our TAVR valves look about the same as they did on CT. But then they went a step further. They created this setup where they took a light and they shined the light down over the TAVR valve onto a piece of paper, and then they literally just took a picture of that piece of paper and said, where did the light come through around the valve? Because that's where we think there's going to be PVL. And so they did that, and then they compared it to actual echo images of PVL. And as you can see, they had 6 true positives, 3 false positives, 5 true negatives, 2 false negatives. So it needs a little bit of work, but at least a first attempt to say, can 3D printing be used to predict PVL in TAVR? And the authors actually ended their paper saying, look, there are a few more steps we need to actually get to this, what they would consider holy grail. And a couple of things I've highlighted here. We need a wider availability of printers with multi-material capability. That's still pretty difficult to do. And we actually need a mock-up of these valves. Either that or we have to get examples of these valves from manufacturers, which is not easy to do. All right, and here's what everyone wants to get to. This is actually a 3D print of an ascending aorta with a TAVR valve on the catheter that they're trying to deploy prior to the procedure to understand the sort of mechanics of deployment. And this was a single case study. And not to leave out the mitral valve, there are people actually now printing mitral annuli based on 3D TEE measurements. And again, everything you've seen so far has been based on tomographic imaging, CT and MRI, but there is data out there now looking at using 3D echo to do these prints as well, although it is more difficult at this time. And then just to give you a flavor of how this is being used in left atrial appendage closure, what you see on the bottom here is actually a print that we did here at Duke, and I've got the anatomy labeled for you because we haven't done it in the pretty colors. But there's a couple case studies out there of people scanning, using a CT scan for a patient to understand what their left atrial appendage anatomy looks like, and then actually 3D printing based on that CT scan, and then CT scanning the 3D print, which is made out of rubber, then putting the Watchman device in there and rescanning it and looking for the change in dimension. The change in dimension can then be turned into pressure points. We know if a dimension increased in this direction, there must be pressure on this part of the left atrial appendage wall. And this particular device works on pressure. So these are the types of applications for 3D printing and left atrial appendage closure. Okay. So I would just say, where are we with 3D printing right now to sum up the data you've seen? We can show, again, in case studies that there's anatomic correlation, that we can basically print what we see on a CT scan. We've done one or two cases here in the literature of physiologic correlation, but this certainly needs a lot more work. And then we really are beginning to enter step 3. We need to actually show that we can improve either people's ability to understand the anatomy or actually improve some sort of surrogate outcome by using 3D printing. And then that will need to move to cost-effectiveness studies. All right, so to summarize, 3D echo is superior to 2D echo in evaluating valvular structure and function. And in some cases, annular size, prediction of PVL, 3D echo may be comparable to CT. Intraprocedural fusion imaging may facilitate communication with the interventionalist and surgeon. And 3D printing holds promise for facilitating diagnosis, procedural planning, and limiting procedural complications. And I would emphasize promise. Thanks.